Introduce our first speaker, the keynote talk by Dr. Ernesto Schiffrin. He's coming to us from McGill University, where he works on mechanisms and treatment of hypertension, and he's had a very distinguished and productive career, and we look forward to your talk.
Thank you, Dr. Gould, and thank you to the organizers for inviting me. What I'm going to be discussing today is small arteries in a number of cardiovascular diseases. Yeah. And I will discuss predominantly human work, but also some mouse work that we do, and work coming from both my laboratory and that of other investigators. Nope. So, help. So what happened here? Yeah. So this didn't work. Of course not. Yeah. So why doesn't it advance? Yeah. But it doesn't advance. Not good.
I got it here.
Yeah.
On your computer.
Let's turn it off. No, there we are.
Okay, now go F5.
There. Sorry for that. These are the collaborators and students and fellows who've done a lot of the work over the years. And, of course, they've done it while I've traveled and talked about their work. What I'm going to be discussing today is this segment of the circulation, small arteries that are vessels between 100 and 300 microns in lumen diameter that participate in generating peripheral resistance and are therefore part of what we call resistance arteries that also comprise arterioles that are smaller than 100 microns in lumen diameter. And these vessels from humans and from rodents have been studied in our lab, mostly using pressurized myography, but also using the wire myograph of Halpern and Mulvaney that goes back quite a few years to the time that these investigators developed the study of small vessels. And what we've been able to show using subcutaneous gluteal biopsies in our controls and in patients with hypertension, with diabetes, with chronic kidney disease, and other conditions, is the morphometry, the mechanics, and the function of these small arteries. And we've also shown that these vessels in the subcutaneous gluteal tissue resemble the changes that occur in rodents in the mesenteric circulation, in the cortex of the kidney, and in the microcirculation in the heart. And so we believe that these vessels are representative of changes that occur in more important vascular beds. And as you can see in this image, typically essential hypertensive patients exhibit a decreased lumen diameter and an increased media to lumen ratio, but no increase in the media cross-sectional area, indicating that they don't have true vascular hypertrophy, but rather what has come to be called inward, because the lumen is smaller, eutrophic, because there is no hypertrophy, remodeling. Inward eutrophic remodeling. And different studies, going back to Bjorn Falco, have suggested that in fact, when remodeling of vessels is eutrophic, vascular constriction will generate more resistance than when remodeling is hypertrophic or in comparison to the normotensive individual. This schema over here shows you the difference between eutrophic and hypertrophic remodeling. Here, the media to lumen ratio is increased, but the cross-sectional area is not altered. Whereas in hypertrophic remodeling, the media is enhanced, is increased, and the cross-sectional area is greater, and therefore this is true vascular hypertrophy. Interestingly, from our own studies in rodents, it looks like angiotensin II appears to be involved in generating eutrophic remodeling, whereas endothelin may produce hypertrophic remodeling, and I'll come back to that later. In these patients, we used electron microscopy to study the composition of the vascular wall, and this showed that the number of layers of smooth muscle was unaltered, that the volume density of smooth muscle cells was similar, but the relation of collagen to elastin was significantly increased. And in fact, we have suggested that the remodeling of the extracellular matrix is the fundamental change that occurs in these vessels. In fact, this is shown here, where a normotensive and a hypertensive vessel are depicted from confocal microscopy, and you can see the yellowish, greenish deposition of collagen, which is absent in the normotensive, and this is shown over here. The typical change that occurs in human essential hypertension is this eutrophic inward remodeling associated with deposition of collagen and fibronectin in the media. Now, how does this occur and why does this occur? And I think in that sense, you heard yesterday from Gerald Meininger, and we were interested in this not very busy slide, that the remodeling of the extracellular matrix may relate in part to changes that occur in integrins on the surface of smooth muscle cells. These are the molecules to which the extracellular matrix components adhere, and particularly in the case of alpha V beta 3, which is the fibronectin receptor, or alpha 5 beta 1, we were able to show enhanced expression of these integrins in this particular paper in spontaneously hypertensive rats, which could be modulated by treatment with inhibitors of the renin-angiotensin system, such as ACE inhibitors, fosinopril in this case, or an angiotensin receptor blocker, irbesartan. Similar data with another model, the REN2 model, was shown by Tony Hegarty's group in Manchester, who demonstrated that in this angiotensin-dependent model, there was an enhanced expression of a number of integrins, including, and I can't see over here, but maybe you can read over there, some of the alpha 5, alpha 7, as well as beta 3 integrins were increased. And we believe that at the time we thought that these changes in integrins could somehow drive the changes or contribute to the changes that occurred in the extracellular matrix in these vessels, both in experimental animals and in humans. We thought as well that perhaps the topography of these integrins changed in hypertension. We didn't really have a good proof of this, and we kind of abandoned this field. And it was really nice to see the data from Gerald Meininger yesterday showing the increased adhesiveness of the surface of the smooth muscle cell, the increased stiffness of the smooth muscles with atomic force microscopy, and the changes that probably he is demonstrating that somehow relate to what we had proposed at the time, contributed to remodeling of the interactions between adhesion sites on the surface of smooth muscle cells and components of the extracellular matrix. Now, what other contributors to the remodeling of vessels? Well, if we could lower the lights. Better not. Oh, he's coming. Okay. This simply shows from human small vessels using the DHE technique how the media of the vessels from hypertensive individuals lights up because of the increased oxidative stress. In a study that we published in Circ Research a few years ago, we demonstrated the presence of all the components of an NADPH oxidase, and in a parallel study in mice infused with angiotensin II, we were able to show that using apocynin, which at the time we thought was a relatively specific inhibitor of an NADPH oxidase. Today, there's some controversy on whether it's more of an antioxidant, but the fact is that this suggested at the time that indeed NADPH oxidase was the main source of reactive oxygen species in the vascular wall in response to angiotensin, and could be driving many of the changes. And indeed, when you blocked NADPH oxidase, remodeling induced by angiotensin II in small arteries in these mice was abrogated. Deposition of collagen, shown in this panel, was significantly decreased when NADPH oxidase was activity was reduced, and endothelial dysfunction, as shown by acetylcholine-induced relaxation, was as well restored with respect to the impairment found under angiotensin II infusion, suggesting indeed that NADPH oxidase activity and the generation of superoxide in the vascular wall contributed to many of these changes that we were finding in the small arteries in experimental animals and in humans. Now, I've shown you endothelial dysfunction. Indeed, endothelial dysfunction is present in humans at the level of small arteries, with intermediate levels of impairment in the case of individuals with borderline hypertension. However, when we looked at our cohort, the manifestation of target organ damage at the level of small arteries was predominant for the structural remodeling of these small vessels, whereas endothelial dysfunction, at least as measured by acetylcholine-induced relaxation, was only present in about 60% of individuals, and, however, more prevalent than left ventricular hypertrophy, at least ECG evaluated left ventricular hypertrophy. So at the time, we suggested that structural remodeling of small arteries in essential hypertension was one of the earliest manifestations of target organ damage. And whether it has a role in the development of hypertension or it is a consequence of hypertension remains to be determined. Now, is it important to study small arteries in hypertensive patients? This data coming from the group in Brescia suggests that yes, that these small vessels correlate with cardiovascular events. And what they show here is that the individuals, the hypertensive individuals who had the higher level of remodeling with medial lumen ratios increased beyond 0.11 in their particular setup had a decreased event-free survival. Now, what about the natural history and contribution of small artery remodeling to hypertension? This is actually based on studies coming from Framingham, where they looked at evolution of hypertension over 10 years. And they found, this paper was published originally by Stan Franklin, and showed that pre-hypertensive individuals in the Framingham cohort, after 10 years, developed isolated systolic hypertension, that isolated diastolic hypertension that is found mostly in individuals who are smokers, male, and have abdominal obesity, evolved over 10 years mostly to systodiastolic hypertension, and that isolated systolic hypertension at the beginning of this period in the Framingham cohort resulted after 10 years mostly in an evolution towards systodiastolic hypertension. And our interpretation was that presence of small artery remodeling in pre-hypertensive individuals through reflected waves that increase systolic blood pressure and contribute to stiffening of the conduit vessels of the aorta resulted in isolated systolic hypertension. In isolated diastolic hypertension, small artery remodeling contributing to increased peripheral resistance, again through reflected waves, led to increased systolic and eventually systodiastolic hypertension. And in the case of isolated systolic hypertension, the pulsatility, the enhanced pulsatility of isolated systolic hypertension transmitted to the peripheral vasculature by the increased stiffness of the aorta resulted in vascular injury at the level of the microcirculation and small artery remodeling and systodiastolic hypertension. And evidence for this comes from Gary Mitchell in Boston, who in this particular study was able to show the relationship between both the forward wave and the pulse wave velocity. These are measures of stiffness of the aorta and both basal and hyperemic forearm vascular resistance, suggesting indeed that there is crosstalk between large and small vessels, and that when small vessels are remodeled through reflection, they contribute to increased systolic blood pressure and stiffening of aorta. And a stiffer aorta, through increased pulsatility, increased pulse pressure, impacts on the small arteries and smaller arterioles and results in vascular injury and remodeling at that level. And there's been quite a bit of speculation about this, and many of us are trying to demonstrate that indeed that crosstalk between large and small vessels is in fact occurring. So let me move on to another cardiovascular disease, obesity. This is a study that we did in collaboration with Professor Mancia in Milan, and these were obese, morbidly obese, normotensive individuals. So what was the morphometry of small arteries in the subcutaneous tissue of these individuals? Surprisingly, they exhibited hypertrophic remodeling. there was just a tendency to a smaller lumen, but media to lumen ratio was significantly increased and cross-sectional area was also increased. So these individuals present hypertrophic remodeling mechanism, perhaps increased growth factors associated with the process of obesity. In the mouse, we've looked at a metabolic syndrome model, the New Zealand obese mouse, and we've been able to demonstrate as well in these mice that have barely elevated blood pressure but insulin resistance and obesity that media cross-sectional area of small arteries is indeed enhanced, that this is associated with increased inflammation as demonstrated by infiltration of macrophages in the perivascular fat, increased superoxide generation in both mesenteric and aortic perivascular fat, as shown by an increased oxidative stress, as shown by DHE technique, increased superoxide at this level, and finally, increased TNF-alpha and decreased adiponectin. This decrease in adiponectin agrees well with data coming from Tony Hegarty, who looked at obese subjects and looked at the responses of vessels and demonstrated the existence in normals of perivascular fat-derived anti-contractile factors that result in decreased contraction, which are absent in obese individuals. Interestingly, the use of an adiponectin blocker results in a decrease in the anti-contractile effect found in perivascular fat of obese subjects. And actually, Dr. Greenstein is somewhere in the audience, or I saw him yesterday. In fact, a more recent study published last year in JACC from the same group in Manchester showed that bariatric surgery by reducing obesity results in a reappearance of the anti-contractile function of perivascular fat. This is associated with decreased inflammation, and all of this is demonstrated here. And you can see that essentially the vessels recover their anti-contractile effect after bariatric surgery. Now, what about diabetes? This study coming again from Brescia showed that in diabetes, what we find, and perhaps I'll just show this schema down here, in comparison to essential hypertensives who have inward eutrophic remodeling and collagen deposition in the vascular wall, and in that they reproduced our findings, normotensive diabetics have hypertrophic remodeling, and hypertensive diabetics have hypertrophic remodeling with collagen deposition. And that is, the collagen is shown here in hypertensives increased, and in hypertensive diabetic patients increased as well. Now, in diabetes, the vasculature is in fact inflamed. And not only is there inflammation, but the remodeling and hypertrophy are exaggerated. Here, in a study that we did, we showed that for equal, actually not equal, these patients were diabetic patients who had blood pressures of 145/85. The blood pressures at the end of UKPDS, meaning that these are the blood pressures at which these patients benefit enormously from antihypertensive treatment. These are untreated hypertensive individuals with increased media to lumen ratio. And even though they have elevated blood pressure, the remodeling of found in diabetic hypertensive individuals is much greater at much lower blood pressures, underlining the severity of vascular injury in diabetic subjects already present at the small artery level that is associated with the severely increased vascular risk of these subjects. What about endothelial function in diabetic subjects and hypertensive diabetic individuals? Well, this coming again from Rizzoni's work, the Brescia group, shows that endothelial function here, both for acetylcholine and for bradykinin, that has an EDHF component, in contrast to acetylcholine, that is mostly nitric oxide mediated. Hypertensive individuals have impaired relaxation, hypertensive, essential hypertensive diabetic subjects and diabetic individuals who are normotensive both have similar degrees of impairment of endothelial function. I'll move on now to subjects with diabetes, but what about their coronary vessels? This is coming from, again, from Tony Hegarty. They dissected out small arteries from atrial appendages during CABG and studied their structure, for which they did not find dramatic changes, and their distensibility. And you can see here that the stress-strain relationship is significantly altered and the stiffness is increased in diabetic hypertensive individuals. From the Glasgow group and John McMurray, studies of small arteries in the subcutaneous tissue in heart failure. These vessels did not present significant morphometric abnormalities. However, they had significant changes in vascular reactivity. And you can see here to different agents, and I can't see in my screen, but there's norepinephrine, there's angiotensin, and I can't see very well, but there's also relaxation by acetylcholine, bradykinin, and essentially what they were able to find is impaired endothelial function and impaired contractility. So small arteries in individuals with heart failure are altered in the subcutaneous tissue. I don't have a slide, but I heard yesterday somebody asking questions about syndrome X. Tony Hegarty did a study in subcutaneous vessels, small arteries from gluteal biopsies in syndrome X individuals. So patients with angina symptoms, but no coronary artery obstruction, so microvascular disease of the heart, and was able to show altered media to lumen ratio, so changes in the structure of these vessels in the periphery, suggesting indeed that syndrome X is systemic. That was a question that was asked by somebody at some point at the end of the day yesterday. Let me show the only brain study that I'm going to show, because Dr. Yadekola will certainly expand on this field later. This study is a special study coming again from the Brescia group. They took advantage of brain tumor surgery to dissect small arteries from the peritumoral tissue of the brain obtained in surgery. And what they demonstrated was, in the tissue, on the one hand, there was capillary rarefaction that you can see over here. and from the point of view of vascular structure, essentially they found in hypertensive compared to normotensive individuals a number of small changes that actually did not achieve significance except for the media to lumen ratio that was enhanced. And as I said, the microvessel density that was decreased in the hypertensive individuals. And here is some confocal microscopy that they published in this particular study that I, as editor of Hypertension, rejected for hypertension. And they published it in Journal of Hypertension, but that's another story. Anyway, let's move on to treatment. Does treatment change structure or function of small arteries in humans? This is the first study that we published over 2 years of treatment with an ACE inhibitor, cilazapril, compared to a beta blocker, atenolol, with equal lowering of blood pressure. We had normotensives that we studied on one occasion, but two groups of individuals to make sure that we were not having any drift in our data. Over the 2 years that we performed the study, and as you can see, there was no effect of the beta blocker, atenolol, and this may be peculiar to atenolol. But under treatment with the ACE inhibitor, inhibition of the renin-angiotensin system, progressive improvement of media to lumen ratio of these small arteries from the subcutaneous tissue in these hypertensive patients, with equal lowering of blood pressure under both treatments. We were able to show the same thing in this study. That is my most cited study. I'm very proud of it. It was a difficult one, like all these studies are, because they're invasive, because patients have things that happen to them, and they're much more difficult to work with than rodents. That's why I do 60 to 70% of work on rodents and only 30% of my work on humans. And in this particular study, we were able to reproduce what we had found with an ACE inhibitor, with an angiotensin receptor blocker, reverse remodeling of the inward eutrophic remodeling found in the hypertensive individuals, with no change with atenolol. And in many studies, atenolol has been our negative control. Blood pressure is lowered, no change in structure or function of vessels. And I'll show you a couple more slides about these effects. Here, I'm just showing maximal responses to acetylcholine and sodium nitroprusside in these vessels. And you can see that under the ARB, there is total restoration of the endothelial function and no change under atenolol. Wondering whether we somehow selected a peculiar population to be treated by the beta blocker that did not respond, we then switched patients who had been treated with atenolol and had not responded and treated them with an ARB. And again, they responded. And as you had seen earlier, over 2 years, atenolol had not produced any effect on the structure of vessels or on endothelial function. And so this meant that this was not a peculiar selection, one, and two, that it wasn't an effect of the second year. And so we were quite confident that this allowed us a conclusion that was quite robust, that blockage of the renin-angiotensin system effectively improved both structure and endothelial function of small arteries. Another study that we performed was with a particular peeve of mine, which is aldosterone and its effects in hypertension, and here we performed mineralocorticoid receptor blockade of patients over a year, and we did not find improvement of structure as shown by medial lumen ratio or cross-sectional area of vessels or endothelial function. That was quite surprising. However, stiffness of vessels was significantly improved by the mineralocorticoid receptor blocker eplerenone, which is a selective mineralocorticoid receptor blocker. And again, atenolol, our usual negative control, only worsened the stress-strain relationship, indicating, if anything, a further stiffening of these vessels. And when we looked at collagen-elastin ratio, the ratio was significantly decreased by eplerenone, and in fact, if anything, it was worsened under atenolol over here. Diabetic subjects treated with renin-angiotensin blockers also improve from a point of view of structure, endothelial function, and stiffness of the vessel wall. And so it looks like in a number of conditions we are able to improve these vessels, and hopefully they are representing what is happening in more important vascular structures. And maybe these results explain to some degree what trials have demonstrated in the sense that these agents are able to improve outcomes. Now let me move on, because we're talking about diabetes, to PPAR gamma. That has been another particular peeve of mine. For many years we've been able to show that PPAR gamma activators seem to have a vascular protective effect. And this is just one slide from a publication that we had in circulation, where we showed that angiotensin effects on blood pressure, on remodeling, on inflammatory mediators, on adhesion molecules, as shown here, were abrogated by the use of pioglitazone or rosiglitazone. And then came the famous meta-analysis with 5 editorials, and these drugs almost fell by the wayside until Barry 2D, which has shown that, in fact, they do not produce heart attacks. They do produce heart failure, but they don't produce heart attacks. And so maybe some of their vascular protective effect is real. As part of those studies, we have more recently performed an inducible tissue-specific PPAR gamma knockout in smooth muscle cells using Crelox technology. And again, this is a rather busy slide, and I can't see anything on my screen, but what we were able to show in these mice infused with non-hypertensive doses of angiotensin II was that when PPAR gamma is knocked out in smooth muscle cells, there is enhanced inflammation by angiotensin II, there is enhanced remodeling, there is enhanced oxidative stress production, and there's enhanced impairment of endothelial function, suggesting that indeed PPAR gamma in the vascular wall is vascular protective. And maybe there will be drugs that will be developed that will have less side effects than the ones currently available, and that, as I say, at least in North America, have fallen almost totally by the wayside in the treatment of diabetes. And at the time, we thought that actually we could perhaps use them in other subjects for vascular protection. In fact, we have a study in British Journal of Pharmacology where we showed that tiny doses of a PPAR gamma and PPAR alpha which probably would not have side effects, actually potentiate each other and have enhanced vascular protective effects at the level of small arteries. Now, one of the last things I have to say in the 3 minutes that remain is our work on chronic kidney disease patients. So this study carried out by Marie Brier, a nephrologist from France, from Paris, from Hôpital Européen Georges Pompidou, who spent 3 years with us doing biopsies of gluteal subcutaneous tissue, looked at media to lumen ratio of small arteries in stage 4, pre-dialysis, chronic kidney disease patients. And you can see here that although blood pressure was as high as that of hypertensive individuals, they had less vascular remodeling. In fact, they had a hypotrophic vascular remodeling, which for us was extremely surprising since these patients have low-grade inflammation and they do have enhanced inflammatory mediators, and they have a hypercatabolic state which may relate to the hypotrophic remodeling occurring in these small vessels. Interestingly, they have less stiff small arteries, although their large arteries are much stiffer, which has been well demonstrated precisely by the group that Marie Brier came from, Stéphane Laurent and Pierre Bouturi. But interestingly, when they study carotids of chronic kidney disease patients, they find the same hypotrophic remodeling. So it looks like it may be the hypercatabolic state of end-stage renal disease that leads to this hypertrophic remodeling of small vessels. One of the things that has been noted in chronic kidney disease is the fact that treatment with erythropoietin is associated with increased cardiovascular events, rather surprising and unfortunate development. So we looked at the effects of erythropoietin on these small arteries and endothelial dependent relaxation using acetylcholine, and increasing doses of erythropoietin in fact impaired endothelial function. And this effect could be blocked by an endothelin receptor antagonist and by a superoxide dismutase mimetic, indicating that probably via ETA receptors, oxidative stress was contributing to decreased bioavailability of nitric oxide and impaired endothelial function. Furthermore, we exposed these arteries to erythropoietin and showed increased endothelin expression in these vessels. They also have increased ETA receptor expression, particularly in those individuals who have a history of cardiovascular events. Now, speaking about endothelin, we've been, of course, interested in the effects of endothelin for many years on small arteries. This shows one of those studies where we've been able to show that in that mineralocorticoid activation results in increased endothelin production. Angiotensin does the same thing, and this can be blocked by an ETA receptor antagonist or by a mineralocorticoid receptor antagonist. And I have often said that a mineralocorticoid receptor antagonist may be the poor man's endothelin receptor antagonist, since endothelin appears to be very responsive to aldosterone infusion. In hypertensive individuals in small arteries, we showed using in situ hybridization that endothelin expression is enhanced, shown here with the antisense. Here's the sense for specificity, and these are severe hypertensives, which has led to the study of endothelin antagonists in refractory hypertension, successful at the ambulatory blood pressure level, but not so at the office blood pressure level, for which reason the company ditched dariocentin, unfortunately, at the same time that the Simplicity trials were showing effects of renal denervation, and before Simplicity 3 made this intervention controversial. We have an endothelin overproducing mouse that overexpresses human endothelin in the endothelium, and it is associated with small artery, hypertrophic remodeling, endothelial dysfunction, and inflammation in the vascular wall. My time is up, so I'm going to skip the immune effects on small arteries. I will also skip the fact that now there's techniques to look at retinal vessels as a window to small arteries. With that, I will just go straight to what have we learned? Structure and function and mechanics of small vessels in a number of cardiovascular conditions, the role of renin-angiotensin, aldosterone, and endothelin, and PPARs, oxidative stress and signaling pathways, the role of the remodeling of the extracellular matrix, and the benefits of blocking the RAS and endothelin. And remaining gaps, I think that we have to have new models with gene inactivation or transgenic overexpression. We need new non-invasive imaging of small arteries for humans, perhaps ultrasound or other. Better understanding of the remodeling of the extracellular matrix. And finally, novel treatment targets, and we're actively looking at the vascular wall for new targets. And thank you for your attention.
All right, thank you very much. I think we have time for one brief question. If there's anyone with a question, please step to the microphone. Good. It's not on, I think. There you go. You want to just step up here?
Sorry for this. So you showed a lot of data about structural remodeling and constriction. Would you mind commenting on myogenic tone? So how does structural remodeling relate to myogenic tone? And are there difference between different hypertension models?
Well, that's a very interesting question. And so there have been some studies on myogenic tone. Actually, Tony Hegarty has two studies, one suggesting that myogenic tone is enhanced in early development of hypertension and may contribute through this enhancement of myogenic tone to vascular remodeling. There is also a study in the diabetic subjects where they demonstrate a significant reduction in myogenic tone and suggest that the reduction in myogenic tone in this particular setting is associated with hypertrophic remodeling due to the impact of the pulsatility associated with a decreased myogenic tone. So there is some evidence that myogenic tone may have a role to play in vascular remodeling of small vessels from some of these studies, indeed. Thank you.
All right, thank you, and we'll move on to our next speaker.